All right, everyone, we're gonna go ahead and get started since it's 12. Can y'all hear me okay?
Yes.
Yep, okay. All right, so over the summertime, I worked with Dr. Stevens in it's something I call picking up the pieces, and it's navigating PICC line use and people who inject drugs with infective endocarditis. A little about myself. I'm a second year MD and PhD student at LSU, and I worked as a ER tech for about 2 years before I started school, so hands-on experience in high pressure settings. And I'm passionate about infectious diseases, epidemiology, and improving patient care outcomes. So some disclosures, I'm not getting paid to do any of this, but I am getting credit for my practice experience course, and I need to meet these competencies. And to make it easier on myself, I made some learning objectives just so we can keep it organized and focused. And references will be at the bottom left, and competencies and learning objectives will be at the bottom right. So what is infective endocarditis? It is a complex threatening infection by bacteria or other pathogens entering the bloodstream and attaching to blood vessels in the heart's lining, or most commonly one of the valves circled right here. Risk factors include congenital heart disease, previous surgery, or IV drug use, and treatment is usually a long course of IV antimicrobials through a PICC line or heart surgery. If it's untreated, it can lead to a bunch of different complications, including heart failure, strokes, or organ damage. PICC line is a preferably inserted central catheter. It is a long, thin tube that goes from the arm to the back of the heart, and one end stays near the superior vena cava of the heart, and then the other one's outside the body. So why do you use a PICC line? Uh, it was first used for nutrition through an IV back in 1975, but has been adapted for chemotherapy, long-term blood product administrations, or outpatient antimicrobial therapy, OPAT. I found this cute little cartoon by this person who makes childhood cancer cartoons, make it easy to understand. It's like, this is my PICC line. It's a little wing. It has a little tube that goes inside my body where my blood is. It has lots of uses, and take some blood, give the body a drink, give the body some medications, give it some blood. And it's important to keep it clean and not wet. It reduces needle sticks. It allows easy access to the patient's bloodstream, and allows medication to be given at home with proper training. So what is OPAT? It was first used in the management of cystic fibrosis in 1974, and it's now adapted to use when a patient has complex infections. This includes sepsis, osteomyelitis, or infective endocarditis. Patients with these infections are usually admitted to the hospital for supportive care and intensive IV antibiotics until they're about stabilized, and then they're usually sent home with a PICC line to be given medication at home or an outpatient basis. This is NFL kicker Lawrence Tynes. He underwent OPAT due to a MRSA infection that led to osteomyelitis in 2013. Some risk and complications: infection, malpositioning or accidental removal, bleeding, blood clots, mechanical device failure. And there's always a question of, if someone who has an opioid use disorder, can they use it to inject drugs? Or is that based off stereotypes? I'll learn more about that later. What is a substance use disorder? It's a treatable chronic disorder with episodes of remission, characterized by loss of control of the substance use and compulsive use, despite the harms it might bring in. So there's cravings to use a substance, neglecting other parts of your life, continuing to use even though it's causing problems, taking the substances in larger amounts and longer doses than you're meant to, and wanting to cut down but not being able to. And it is defined as a disability under the American Disabilities Act under certain circumstances. Some statistics about this: about 10% of all infective endocarditis cases are associated with IV drug use. The number of deaths with infective endocarditis associated with drug use has increased exponentially. This graph right here. One study in Oregon reported that there was an 18-fold increase in hospitalizations due to the sepsis caused by IV drug use between 2008 and 2018. And rates have increased in the US since then. It mostly affects patients between or under the ages of 35 here. Over 100,000 persons in the US died from drug overdose in 2020, and it only got worse due to COVID. This is a period effect. This is a period effect observed right here between right when COVID started. There's this giant jump in opioid deaths. And that's on a national level. What about our state? Well, the state follows the same trends right here. And these are just parishes that affects the most with that age group about the same on a national level. So what are some things to consider with people who inject drugs? Many people are unhoused or have unstable living conditions. Many have co-occurring mental health issues. Many face stigma. Many face racism and discrimination daily that might intersect with each other. And many come from a disadvantaged background. And I'd like to point this out because if you look at this picture right here, these two big circles are UMC and LSU. And this picture at the top was taken right here. Shows you how close to home it was. I pass this every time I come to school, and it's sad to see. So some stigma that's associated with it. Some patients are treated fine until they disclose that they have a substance use disorder. There have been many qualitative studies showing that they have negative experiences once they disclose it. There have been a push to curb the stigma by changing the language used associated with it. So right here, you don't call them drug user, you call them a person who uses drugs. You don't call them a injector or a junkie, you say it's a person who injects drugs. You don't call them a pothead, chauffeur, or a meth head, you call them a person who smokes drugs. Here's some quotes from patients. In general, they tend to be a little stricter with you. They tend to be more short-tempered with you. They tend to presume what you need instead of a conversation, and they do not get to know the person. They just assume that we're all going to do the wrong thing. So can we trust someone with a substance use disorder with PICC line for OPAT? It seems a little counterintuitive. They have access right to their bloodstream. It's been widely debated since the early 2000s. There's this opinion piece by this ER doctor saying, is it acceptable to discharge a heroin user with an IV line to complete his antibiotic therapy for cellulitis at home? He cited reasons like overwhelming temptation, contamination from unclean needles and drugs, and other health complications such as infection or causing air embolus is the reasons why you shouldn't. And that was quickly countered by one of his students, a fourth-year med student, applying, yes, supervised home care assumes treatment at a lower cost, saying that these doctors have a duty to care for their patients, keep healthcare costs low, and respect the patient's wishes and values. And someone like to point out right here, these articles are showing their age, discharge a heroin user, just talking about changing the language. So it's been going on. So what does modern research say? Some say no, OPAT is risky and has potential for many complications. Some say yes, OPAT can done be safely and select people who inject drugs. There are many studies showing evidence for and against it. Let's look at some strengths and weaknesses. One study by Roger et al. Looked at 3 hospital systems and a recurrence of complications in this group of people. They showed higher recurrence of infective endocarditis in people who inject drugs, particularly in patients who abuse their PICC lines. Some strengths, it had a decent sample size. It was a long-term study, and it showed that fungal infective endocarditis had a higher odds of occurring in people who inject drugs in their second time of infective endocarditis. And they acknowledged their weaknesses in the study as well. There's some issues with the study, though. Number one, the definition of PICC line abuse is broad. They rely on suspected tampering or misuse instead of evidence or asking the patient, which leaves it open to interpretation. There was a median time of 1.23 years between the first and second episode of endocarditis. So it's hard to conclude if there's an actual correlation between these two. And there was a low referral rate to supportive or substance use treatment programs in the first and second episode of endocarditis. One common trend among all these studies showing against it is it's not really the individual that's the issue, it's the lack of addiction care. So lack of proper follow-up and continuity of care, the lack of psychosocial support services, and adequate outpatient addiction services. One study showed that there was a decrease in the readmission rates, which led to better health outcomes. Then there was another study that showed a qualitative, semi-structured interview type study in people who inject drugs and the challenges they face in receiving care. And they used journey mapping, which was something mostly used in business models to see how people consume products or go to the store and buy products. So it's an interesting take. 3 themes emerged. So for this patient right here, the top right, it was so one patient received addiction care treatments and the other one didn't. If you look at the time frames right here, though, it's like, oh man, did they do that thing where they adjust the graphs to make the results look better? Not really. If you look at the acuity of care. So if you look at intensive hospital care right here, this patient who didn't receive addiction care had to use the ICU more and get admitted to the hospital more compared to the one who did receive addiction care. Yeah.
And the sort of top of the side.
Yeah.
So where's the new airline? The red?
Yeah, it's going to be the little L right here when they leave care by choice. So theme number 2, they left care due to unmet pain needs, unmet withdrawal, discriminatory behaviors between healthcare staff, and prolonged periods in care triggering mental health comorbidities. This first patient left care 3 times due to her opioid use disorder and endocarditis due to untreated withdrawals. After the delay, she was admitted to surgery for a valve replacement. And post-op, she had a long hospitalization with post-acute care, intensive outpatient follow-up, where she was engaging in addiction treatment and cardiac and infectious disease care. Other participants experienced several long periods of remission from opioid use disorder and sought out addiction care promptly following her return to substance use on multiple occasions. And on one particular moment, she described going to meet out her dealer and continued to use drugs, but instead went to the emergency department for care, explicitly attempting to reconnect to her addiction treatment. So, right, yeah. Yeah. And theme number 3, there's some psychosocial issues as well. There's transportation issues, other life obligations like work, family needs, and unmet pain withdrawal again. So this first patient up here, after his first prolonged episode of opioid use disorder care, he experienced homelessness and staying with different family members. This instability made attending follow-up appointments difficult, causing care lapses, and he eventually had seizures due to missing anti-epileptic medications and return to alcohol and medication opioid use, which led to rehospitalization. The second patient here received addiction care in New Hampshire for about a year before his initial opioid use disorder, but continued misusing opioid pain medications while on buprenorphine. He reported being expelled from his treatment program instead of receiving more intense addiction care, leading to increased substance use, return to injection heroin, and recurrent mitral valve endocarditis, necessitating another lengthy hospitalization. And there's some studies showing that it can be done with some specific circumstances. So this first study here showed that it can be done in select people who inject drugs with this cover on their PICC line. So cover right here, but some issues that people brought up is the ethics of only using the security seal only in people who inject drugs. Because if they walk into an outpatient clinic, it's basically a red flag that says, I use drugs to all the staff there. Another study had a low sample size, and another one had a hard exclusion criteria, which made it difficult to select patients. They initially started out with about 300 participants, but then had to knock it down to about 60 because not many people can follow this hard exclusion criteria. And then there was another literature review right here showing that 72 to 100% of people who inject drugs can successfully complete OPAT. And despite the perception that PICC line misuse would be inevitable among people who inject drugs, it didn't happen as often as people perceive it to be. Many studies from these sides have shown a low sample size, and it's mostly suspected due to many do not have referrals to proper addiction medicine specialists on an inpatient outpatient level. It reflects the lack of available addiction medicine specialists overall, and many healthcare staff are unfamiliar with the ins and outs of addiction medicine. Many healthcare centers lack multidisciplinary care and structure and struggle with good continuity of care. Given these, what do the professional associations like the American Heart Association or the Infectious Disease Society of America recommend without a clear answer? So for historical purposes, I give this is the 2004 IDSA guidelines, and generally they recommend that people who inject drugs are poor candidates for OPAT, and they recommend sending them off to a skilled nursing facility when appropriate, or using oral antimicrobials or injected antimicrobials when appropriate. And they also recommend that you can use some computerized PICC injection equipment if it's available. But they also comment that patients' ability to adhere to the prescribed treatments and the threat of unauthorized vascular access will determine whether therapy outside a hospital setting is advisable. And it didn't change until like 15 more years later. Generally, in the most up-to-date IDSA guidelines, they recommend that no recommendations can be made about whether it can be done, and it has to be done on a case-by-case basis. It showed that injection drug use was found to be a risk factor for vascular access complications. And later state that there was low quality evidence for increased risk of vascular access complications. They give a lot more psychosocial factors to consider, and they recommend some alternative treatments that you might want to consider as well, such as discharging to a skilled nursing facility again, sending patients home without a PICC, but bringing them to outpatient facility for each antimicrobial admission. So starting an IV every time they come in every day, instead of just having that one continuous line, or keeping them in the hospital for the entire duration of their stay. So some cases with oral antimicrobials and injectable antimicrobials have been shown to work. One study shown that it is less inferior and less liver toxic, but it doesn't work in all cases. So some infections or polymicrobial infections are required some stronger antibiotics or some antibiotics that don't have an oral equivalent. And it doesn't work in patients who have impaired GI absorption of that medication. And then they cannot make a direct recommendation for these options, but it requires shared decision-making instead of a paternalistic attitude. The key that they said is not to make assumptions about what the patient will do, but instead talk to them to figure out what will be best for them. So in 2015, the American Heart Association published treatment guidelines for this, and they made a small recommendation for people with a substance use disorder to treatment programs, but didn't elaborate further. Recognizing lack of details in 2020 or 2022, excuse me, the American Heart Association published a review article in circulation called "The Management of Infective Endocarditis and People Who Inject Drugs," and it was much more detailed. So it considered a lot of different things that all the other guidelines lacked. It considered multidisciplinary approaches, better history and physical, medications to treat the underlying disorder, partnerships with the community clinics, and factors considered with OPAT and people who inject drugs, harm reduction education, and secondary treatment options. So they recognize that other hospital systems have found things that work. They recommend infectious diseases, cardiology, cardiac surgery, addiction medicine, psychiatrists, nurses, pharmacists, and social workers. There have been calls to include more staff as well, such as dentistry, peer support workers, systems navigators, etc. But at the bare minimum, they recommended addiction medicine, ID, and cardiac surgery. And it recognized that addiction medicine has been siloed from the mainstream healthcare models. And they comment that treating the underlying, the infective endocarditis won't get better unless you treat the underlying addiction problem. No better history and physical. Go beyond asking, do you use drugs? Instead, get into specifics. What have you used in the past? What do you plan to use in the future? How much do you use? What is your route of use? Asking about previous treatments and how that's worked for them in the past. And asking about previous overdoses and injection complications such as infective endocarditis, HIV, or hepatitis C. And it helps determine the risk of withdrawal and other injection materials or related infections, excuse me. And physical, looking at the skin for previous and current injection sites for inflammation of current infection, the liver for cirrhosis, evaluating oral health, and the assessment of the substance use withdrawal using the clinical opiate withdrawal score, CALS. And being mindful of the stigma and non-judgmental first-person language. So what is CALS? It's to measure the withdrawal severity through observable signs and symptoms. It's looking at, what is your resting pulse rate? Are you sweating? Are you restless? What is your pupil size? Bone and joint aches, runny nose and hearing, minus if they have a cold. Goose flesh skin, so do they have goosebumps, anxiety, irritability, yawning, tremors, GI upset, and they can figure out if your withdrawal is mild to severe. And some questions asked patients that they recommend is going into depth about the substance used, what do you use, opioids, cocaine, marijuana, how often do you use it, when did you last use it, what are your routes of use, how do you cook it, how do you prepare it, and other complications like have you had an infection from it before. And all these give healthcare staff an idea of what complications to think of, such as oral contamination by licking needles. It's a practice sometimes found in people who inject drugs. So some patients' experiences where shared decision-making helps patients in need. Some patients aren't ready for treatments and they go, there's no way that I could be home right now and not try to use heroin. At least I know what's being put in my body. And some say, if I were to leave this hospital right now, I don't think I would make it. But in some patients who are probably ready and know more about their body, or know where they are in their stages of change, excuse me. They say that he makes me feel like really listens and he really cared and it gave me some reassurance. And people who use drugs are treated as non-persons or children in a lot of ways. The biggest thing I can think we can offer anyone is a choice. Dignity is offering all the information, having people choose that. They recommend some medications to treat opioid use disorder, emphasis on getting opioid medications such as methadone, buprenorphine, and extended release naltrexone, as not preventing it could violate the ADA. And they link out resources where providers can get free online training to get their waivers to prescribe this. They recommend partnership with community clinics, such as opioid treatment programs, addiction medicine treatment facilities, patient services for patients, for transportation, medication pickups, skilled nursing facilities, but discrimination is common, more on this later, and medical respite programs for unhoused patients. Currently, there are no medical respite programs per the National Medical Respite programs. Most states have 1 to 3. And then some factors consider are patient preferences, informed consent, feasibility, do they have health insurance? Is there availability of residential addiction treatment centers? And do we have a social worker or case manager to help patients with some of these psychosocial factors? Are they engaged with their substance use disorder treatment? Has harm reduction education been taught? Do they have a safe home? Do they not have any triggers at home? Do they have sober supports, running water, electricity, or working phone so we can call them and check up on them? And do they have transportation to and from appointments? They get this fancy flow chart to help providers go through it, offer all patients the IV medication, limit unplanned discharge, and then use a patient-centered decision-making model. Patients who are not candidates for OPAT should be offered ongoing IV antibiotics in a supervised setting in the hospital or outpatient facility. And if they aren't eligible for IV antibiotics, they can either take the injectable antibiotics or oral medications. And if there's a contraindication for oral medication, such as they have impaired GI absorption, they can take the IM antimicrobial route, or they can take oral antibiotics if there is no contraindications for oral medication. Something they bring up though is that you want to do it on an on-site pharmacy and give it to them at discharge so that you can prevent any logistic issues on their end. They advocate for harm reduction education. It's a public health strategy aimed at minimizing the negative health, social, and legal impacts associated with high-risk behaviors, not just drug use. It focuses on reducing harm without necessarily eliminating the behavior, improvising practical non-judgment approaches to improving safety and well-being. And it's seen in everyday practice, including but not limited to seatbelts, so you don't fly out the windshield, helmets, so you don't bump your head at the construction site, sun protection, so you don't burn yourself while you're out at the beach, and PPE, such as wearing masks in hospital setting, and the lock zone in the case of injection drug use. It is not condoning or supporting the risky behavior. It is keeping you safe if you need to do that behavior. So some key points for safer injection: don't lick your needles, do not lick your injection site, make sure that the site is clean. For providers, they recommend testing for bloodborne infections such as HIV and hepatitis C, and they recommend some harm reduction kit materials that hospitals can implement. And they encourage people to prescribe naloxone upon discharge for anyone with a known substance use disorder, but you can get it over the counter now. But there's also the issue of people might have an issue with cost, so it's something else to consider. There's some more local resources. So they have New Orleans Travelers Aid to assist with on-house patients, Tristerio Harm Reduction Network. They provide fresh syringes, injection supplies, wound care kits, naloxone education, and further linkage to care. They provide, this is about 70-page safety manual on how to safely inject and not to inject at high-risk areas. And if patients are injecting alone, they can call this hotline, Never Use Alone hotline, or use the Brave app to get in touch with someone who will stay with them on the line, collect some basic information like where are you located, and then if the patient is unresponsive, they can call EMS, say we have an unresponsive patient at this location, can you come help them? And this is an example of how harm reduction could help preventive harm. It highlights the importance of medical staff asking the right questions and knowing the ins and outs of substance use, gives opportunities to educate patients about safer injection practices.
When people use heroin in the United States, they generally use white salt heroin, heroin hydrochloride. Heroin hydrochloride, white salt heroin makes up the vast majority of heroin was water soluble. And you put it in your filter, you mix it, you heat it up, you put your filter in, you draw the drug through the filter, and you inject it. So there's a lot that we need to consider. Well, that's important because there's a number of other patients who use black tar heroin, steroidated heroin. The steroidated heroin, black tar makes up about 10% of the heroin used in the United States. The largest portion is outside of the United States. But what's important about black tar heroin is that it's not soluble in water. You require it in a acidic living injection. In the United States, it's generally used in sterile capacity picked up from a needle stinging facility or the underground state injection site, or even if you're lucky enough from the pharmacy or even the supermarket and get a sterile capacity packet, turn your ability to fit it so that you can safely inject this name. But So many of our patients don't have access to these sterile building modifiers. So many of our patients have to substitute non-sterile but acidic diluents to inject their drug. Where they find these non-sterile diluents, they find them in fruit juice, they find them in lemons left on the planet, they find them in vinegar, in the bottles of fiction. And what's more, that this practice of using sterile, using acidic diluents found its way not out the black parts in your knee, found its way into the heroin salt, the white heroin community. So many of the patients are using acidic diluent protection. When failure to ask that question leads terrible, terrible results. So what's happening with melon? Pink eye, pink eye, again and again, pink eye. And I'm intending to run into doing at an academic level on the trauma center with a billion residents. My evaluation of pink eye consists of me walking through the room like this, that's the resident types to know when I take the patient out. But what we didn't do was we didn't ask the question. No, we didn't about pink eye. Melanie, if we knew to an IV drug with ether, Melanie was the non-sterile acidic diluent to inject her hair. What was Melanie using? Actually, lived in a very affluent family, and her mom every morning would cut lemons for her iced tea. Use the lemon, leave the lemon on the counter. Melanie would come down and take the lemon and use it as the acidic diluent for her heroin injection. Why is that a problem? Because every time she was doing that, she was injecting fungal spores directly when she until those fungal spores bound themselves to her eye. And that's not pink eye, that's fungal endocarditis. And we missed it 3 times when I went to the department, so it's 4 times. And no one had to go in mediation. No one died and taken out by our ophthalmologist, no one walked the line. Nobody ever told me that heroin is derived because none of the clinicians know what it means to inject heroin, how to inject heroin. Our clinicians don't understand that our patients are seeking out the acidic diluents for injection, and they're using the lemons left on the counter by the mom, and they're suffering fungal endocarditis, fungemia, fungal bioinfection. All because no one ever asked the question, what is the reason that you go to the preaching to get nothing to do with it? The acid package, what are you using and why? And then speaking with the patient, hey, listen, I know you're using fruit juice, you know that you don't need to do that. You can use water, it's okay. Oh, you're using fruit juice, you're using black tar. Let me provide you with the ability to instill the acid package. This is what harm reduction is. All it does, all it is starting with a simple question. What do you use with your heroin? Why? And it begins your conversation, it begins a relationship with the patient, and it leads to better outcomes for our patients. Melanie, you can look at a young girl who started on perfect death from a fetal toxin, lost her eyes, nobody ever asked her what she was using to cure.
All right. It was a great video if you want to watch the rest of it, but I took that little clip from it. Right. So asking the right questions and then figuring out what are your patients doing to inject the drugs are important, but also emphasize, meeting your patient where they're at. So we can use the trans-theoretical model of change to gauge where the patients are at in their state of change. It's one of the many behavior models used to evaluate someone's readiness for change, and it's divided into stages. It's not the only model, but it's the most intuitive model. So you start at pre-contemplation. It's like, no, I'm not going to change. Contemplation, I might change. Preparation, I might prepare to plan the change. Action phase, I'm going to do the change that I set out to do. And then the maintenance phase is where you keep going with your state of change. And at any time, you can relapse back down or up or go back down. But they emphasize that you can go back to one stage and then make your way back. And so eventually that behavior is completely changed and then in the termination phase. You can measure this with self-evaluation rulers and readiness rulers. So at this point, you can ask the patient, are you ready to make change at all? Not at all. I'm thinking about making change, planning and making change, and then actively changing. You can use that to gauge where they are. And you can use motivational interviewing to hopefully push them along this model of change and figure out what needs to happen so they can get this change done. And since many patients come from many different backgrounds, not every patient will be ready for change in the same ways for intrinsic or extrinsic reasons. And it can be used to push people along to get them to change their unhealthy behaviors. It was first described in 1983 as a brief intervention for drinking. It works by activating a patient's own motivation for change and adherence to treatment. Compared to no intervention, it led to a decrease in the extent of substance use and about post-intervention up to 1 year in one study. And then combining with motivational interviewing with other substance use treatments might lead to better results. More research might be needed. And conversations about behavior change arise when you and your patients are considering doing something different in the interest of health. The way you talk with your patient about the health change can substantially influence their motivation to behavior change. And people are rarely completely unmotivated to change. I used to work in healthcare before I started school, and I've heard things like, he OD'd now, he'll OD again next week. He doesn't want to change. He's just going to be stuck here forever. People deep down might want to change their behavior and knowing it's harming them, but they might not know where to start, given the complex psychosocial factors at play. Motivational interviewing can help find out the reasons why these people are engaging in behaviors and then help them figure out how can they get you back in it. There are some rules to motivational interviewing or more guides if you think about it that way. You can resist the writing reflex. Don't correct the patient or tell them what they're doing is wrong, because they might know that, but they might bounce back and dig their feet into their ways. Understand where your patient's motivations are coming from. Seek to understand their values, needs, abilities, and motivations. Listen to your patient. Have a heart-to-heart. Figure out what's important to them. Who's there for them at home. What are some of the things that happen to them? Some patients that Dr. Stevens have had that come from very difficult backgrounds. They have difficult childhoods, and they would, they come from adverse childhood experiences. That's an example. Empower your patients, encourage them to work together to achieve their goals and techniques to overcome their barriers. You can listen carefully, ask the patient's opinions about being considered, explore the pros and cons of something that they're going to do, and offer what you know about this, offering what you know, but the decision is ultimately theirs. You can ask open-ended questions rather than yes, no to gauge where patients are and what they want to explore. Affirm the strengths and movement in the positive direction. Reflect what the patient says and summarize what the patient said, just so they know that they're being heard. And you want to listen for change talk from your patients. If you hear your patients are going for saying this, you're doing it wrong. And if you're trying to convince them to do something, you're also doing wrong. Vague statements like, I'm going to quit tomorrow, or I'm going to stop using drugs, aren't good enough and are prone to leaving you frustrated that you couldn't complete the goal you set out to do. Instead, you can use the transtheoretical model to gauge where your patient is on at their stage of change and set their goals that way. Good goals in this case of drug use would be injecting 3 times a day, or instead of injecting 3 times a day, I'm going to inject 2 times a day and using coping strategies or medication for 1 week. This is specific because it's not vague, measurable, since you're counting the amount of time they're using, achievable, specifying how they're going to do it, and it's also realistic because if you force someone to go cold turkey, it doesn't work for everyone. And it's also time bound, 1 week. And most importantly, if the patient comes back 1 week later saying that, half the week I did it 2 times, but the other half of the week I resort to 3 times, that's okay. That's still progress. And it should be positively feedback so it can keep going. Some healthcare system challenges, bunch of bias and stigma. You think you got labeled, as a kid, they would tell you that's going on your permanent record. That's how you feel. Like this is going to follow you everywhere you go. I think people behave differently, and there is a judgment that goes on. And then if you treat the patient non-judgmental, you could hopefully have patient experiences like this. In this study, Dr. X was the first person in my lifetime stood across from me and looked me in the eyes and told me that she believed in me. And that she, as knowing for me a couple weeks now, talked to me every day, and she fully believed in me 100% that I can get past my withdrawal and get sober and maintain my sobriety. Some other healthcare challenges is staff burnout and staff biases. Education alone isn't enough to help build this therapeutic relationship with the patients. There's this one qualitative study here that shows if you increase the amount of education alone, the amount of therapeutic intervention actually goes down, even though it wasn't found to be significant. But if you increase the amount of role support, that increases the therapeutic attitude of nurses as well. So patients, it was found that increasing the role support for nurses increased the therapeutic attitude for patients with substance use disorder. This relies on other staff that have experience working with substance use disorder. As you increase that role support, the amount of therapeutic attitude goes up, and that has been found to be significantly associated. Another challenge is resource allocation. While more providers are getting certified to prescribe for opioid use medications, it's not enough to keep up with demands, nor does it acknowledge the complex psychosocial factors that go on. There's not enough opioid treatment centers with modern practices, and people who inject drugs are forced to stay in the hospital for an entire treatment length, which can cost taxpayers thousands, assuming they're on Medicaid. There are also problems expanding access to more providers that can prescribe medications for tailoring treatments with people who inject drugs. This method has been shown to be more cost-effective in retrospective studies and simulated models. If you look here, combined models increase the amount of, or is the cost most cost-effective, along with partial oral treatments or usual care plus addiction services. So if you increase the amount of addiction services and the amount of prescribers who can prescribe addiction medicine treatments, it would help be more cost effective in the long run. So some ethical considerations to consider. Is it wrong to deny a person who injects drugs, OPAT, despite it being the standard of care? Do we force other patients to sign abstinence contracts for things such as smoking or high blood pressure or blood sugar control? And how does this limit the patient's time? Balancing care and harm reduction of societal institutional norms. So you got to think on the provider side of the view, he doesn't want the patient to have harm or die, and he doesn't want to get sued. And this doesn't help because there's no clear-cut institutional guidelines such as UMC and LSU or LCMC, excuse me. And the patient's point of view is that they're not getting their needs met, which only furthers distrust in the healthcare system at large. And it could lead to patients not seeking medical care until the medical issues become advanced, such as infective endocarditis. Balancing these dilemmas of shared decision-making, engaging where the patient is at life and readiness for change, and proper documentation of the conversations might be the best option here. And what about patients who are unhoused? There's not really a good option here besides medical respite or keeping them in the hospital at large. So some legal cases involving OPAT and people who inject drugs is Ledoux versus Good Samaritan Hospital. He had a complex foot wound and was denied OPAT due to having an opioid use disorder, and he was denied medications for his opioid use disorder and forced to go through withdrawal. The provider claimed that there were hospital policies denying PICC line of people who use or people with a substance use disorder, and he had eventually he had a complication that led to his left leg being amputated below the knee. The representatives in the case claimed that he violated these laws here. In the patient reports that the provider said, "I won't lose my license because of some junkie." That's a loaded statement right there. McKay versus Ohio State University. In this case, the patient Jennifer had unmet pain needs after surgery for an ear infection. As a result, the patient resorted to injecting a crushed up Percocet pill in her IV access line while she was in the hospital. This caused a pill fragment emboli and blocked the blood vessels in her lung, which led to acute heart failure, and she eventually died from it. The medical center did not provide adequate addiction care or medication for the known substance use disorder, and this shows that the hospital shows the importance of providing that care for the patients so stuff like this doesn't happen. With the American with Disabilities Act, people with an opioid use disorder typically have a disability because the opioid use disorder itself limits one or more major life activities, and it's considered a physical or mental impairment under the ADA. Denying a patient solely based off their substance use disorder or the treatments that they're getting for that disorder is a violation of the ADA. And these aren't limited to patients who are undergoing an active treatment plan. But there is no coverage for when a patient is actively using drugs or injecting drugs. The lines get blurry when the patient relapses, and there's no clear-cut lines for how long the patient has to be quote unquote clean of substances before these protections come in. It's more of a question for the legal team since there's no clear-cut answers. Despite the shortcomings with despite the protections by the ADA, there's still discrimination seen by skilled nursing facilities. They have been documented to overtly discriminate against people who inject drugs with medical care. And it led to a lot of cases being successfully filed against them, and they got sued. But despite these rulings, they have still been found to deny care to patients with a known substance use disorder, less overtly, however. And it calls to action for healthcare team and the hospital administrative legal team to advocate for their patients with the substance use disorder. And there is a legal action center in New York that provides a great model for advocating for your patients with the substance use disorder. This is a great chart. I like this because it provides instructions not only for people who needs the treatment, the patient, but also the provider, the healthcare administrator, or the hospital administrator, but also the skilled nursing facility. They said that clinicians there can now get buprenorphine through the DA waiver. So it's not saying the hospital just go against the skilled nursing facilities and fight. It's giving advice to all of them. There's a nice little poster that they made. Here are some ways discrimination can happen. Recovery homes will not admit you because you take a buprenorphine. Hospitals will not provide you with surgery or another procedure because of your substance use history. And home care agencies will not serve you because of your drug use. Emergency room does not offer you the medication for treatment or connection to ongoing substance use services in the community after an overdose. And they also provide a template for the legal team or hospital administrators that they can send to skilled nursing facilities that have been known to discriminate against their patients. And it would need to be reformatted if they wanted to use it. Some future directions to consider. Patients having access to harm reduction services, addiction medicine services, better continuity of care in a medical respite facility for unhoused patients, staff having access to bias and stigma education with better peer support, education on substance use disorder and harm reduction in professional schools, a multidisciplinary team in the hospital, knowledge about the community opioid programs, and backup from the hospital's legal team regarding unlawful rejections from skilled nursing facilities. And I'm just going to show my thought process here. This is a direct acyclic graph I made. So the event is withdrawal symptoms, unmet pain, and that can lead to drug use, the unsafe injection practices, which could eventually lead to infective endocarditis. So it's a very complex issue and a large unconventional bag, but it shows how complicated these issues are at a societal level. And if you control stuff like poor continuity of care, lack of addiction medicine services, and lack of harm reduction services, you can effectively remove this outcome from happening in people who inject drugs, which is infective endocarditis. So some conclusions: people who inject drugs with infective endocarditis can successfully undergo outpatient antimicrobial therapy if they meet specific criteria. Implementing a shared decision-making model between the patient and multidisciplinary team, rather than relying on bias and paternalistic approach, is essential for building trust and supporting patients in their journey to recovery. The collaboration approaches patient engagement and enhances adherence to treatment, and ultimately improves healthcare outcomes. And meeting the patient where they are on their journey, using the trans-theoretical model and harm reduction techniques, and employing motivational interviewing to guide them are key factors in supporting their transition to recovery and ensuring better healthcare outcomes. And that's the end of my presentation. If you have any questions, you can ask now or email me later. And please sign in just so I know who was here. I'll take any questions for anyone online as well. Yeah. Person, I don't want, yeah.
I think that's,
For a person, I knew him in undergrad. We did Global Brigade together with the Honduras and provided medical care in the rural community. Yeah. He was like 2 years ahead of me though. Just for now, I eventually plan to go into infectious diseases, so this is kind of correlated with that multidisciplinary team. Um, so I'll leave the door open. And we'll see where the future brings them. Well, I got cookies if y'all want one. I was expecting a little bit more of a crowd, but it's okay. Thanks. Thank y'all. Thank y'all for attending. Yes.